Hello, I'm Norman Swan. Welcome to this programme on obesity. We're one of the most overweight nations in the world, with over 60% of adults and around 1 in 4 children being either overweight or obese. As you know, it's a major risk factor for many chronic problems, including diabetes, heart disease and cancer. Obesity, though, is hard to treat, and that's what we're here to help you with tonight. You'll find a number of useful resources available on the Rural Health Education Foundation's website. That's rhef.com.au. Our panel: Lillian Cow is a bariatric surgeon at Flinders Medical Centre and is also president of the Obesity Society of Australia and New Zealand. Welcome, Lillian.
Thank you, Norman.
Melanie Grice is a dietitian with a special interest in obesity. Melanie is director of Health Kick Nutrition and Dietetics in Melbourne. Welcome, Melanie.
Take you.
Health Kicks? Is it getting a kick out of health, is it? Or are you going to kick us into submission?
Both.
Both, right, okay. Bit of the diet Nazi here, we'll come back to that later. John Pearson is a general practitioner from Tamworth in New South Wales, who's not a Nazi. He's got a passion for encouraging healthy lifestyles in his practice, although there might be a bit of fascism in there somewhere. John, welcome to the programme.
Thanks, Noel. Good evening.
And Boyd Swinburne is Professor of Population Health and Director of the World Health Organization's Collaborating Centre for Obesity Prevention at Deakin University in Melbourne, is also an endocrinologist. Welcome, Boyd.
Thanks.
What do we mean by when somebody's obese? Just give us a reminder on the cut-offs here.
Well, the definitions are around body mass index, and for obesity we take a body mass index of greater than 30. Body mass index is the weight in kilograms divided by the height in metres squared. Super obese or morbid obesity is over 40. Overweight is 25 to 30. So it's not a perfect measure, but it's a good place to start. And for clinicians, of course, they can look at other things like waist circumference and other comorbidities and risk factors.
We got a question before we started from a general practitioner in rural New South Wales asking, why wouldn't you just dump all that and do waist circumference? Isn't waist circumference more reliable?
Well, I think waist circumference is about as reliable, and that's perfectly fine. And I think that in many ways, waist circumference is often an earlier indicator of change. So when people, particularly if they're exercising, may not lose much in BMI, but might lose something around the waist. So waist circumference is perfectly fine to use.
And everything's heading northwards? In terms of obesity?
In terms of where we're going, yes, of course it is. So like Australia, like almost all countries, is increasing overweight and obesity. And the interesting thing is that this kicked off in almost all wealthy and middle income countries about the same time. So in about the 70s or so it started going up, and it's continued in adults. It's continuing to climb, so that we now have almost 2 in 3 adults overweight or obese. And in children, we've had the same pattern. It's increasing to about 1 in 4 children.
And I hear stories of it tailing off, and it's now a postcode phenomenon that, if you go to, Toorak or, you go to the fancy suburbs of each town, you won't see fat people, but you will if you go out to the suburbs.
It's certainly not tailing off in adults. In children, and particularly the under 5s, it may well be starting to plateau or even tail off. So we have some hope in the younger age groups, but I'm afraid not in the older age groups. And you're right that there is a postcode phenomenon. So this is the effect of socio-economic status on overweight and obesity. And in general, people from more disadvantaged backgrounds or postcodes tend to have a higher risk of being overweight or obese. But that gradient across overweight, across socio-economic status, is also seen urban and rural, and it's also seen quite a lot of differentials by ethnic group as well. In fact, the differences by ethnicity are often much greater than they are by rurality or by socio-economic status.
And you'd see both in a country town, John Pearson.
Ethnicity, not so much, because our community is fairly uniform, but the propensity for rural people to gain weight is enormous.
Because, contrary to common expectations, you live in your car or your tractor or your motorbike.
We have patients that will move their car from one block to another because there are plenty of car parks to be had at either end of the street. Yeah. So
activity levels are low and people are... So just give me a sense, because you've got some remarkable figures here about the relative risk of overweight and obesity to diabetes.
So the relative risk of obesity or high BMI for many diseases is of the order of 2 to 3. times. So in other words, risk of cancer, for example, 2 to 3 times the risk of some cancers like breast cancer. But for diabetes, the risk is just phenomenal, and it increases from a BMI of, say, 22, which is where the
I think we've got a graph on this. Let's have a look at that. Yes.
Yeah, so you can see on the graph there that the age-adjusted relative risk on the left-hand side goes up to enormous numbers that you don't see in almost any other risk factor. It goes up 25, 30, 50 times the risk of getting diabetes with a BMI of 30 plus compared to a BMI of under 22. And other conditions, other risk factors that we take very seriously, like high blood pressure, like high cholesterol, like smoking, give relative risks of the order of 2 to 3. These are up to 20, 30, 40.
And of course, Lillian, risk of death is also there too.
Patients who have increasing BMI certainly have a higher risk of dying from their comorbidities. World data have shown that as your BMI increases, your relative risk of dying increases exponentially.
So it goes up similar to that curve.
Definitely.
As well. And what about other conditions, Boyd, the other comorbidities? You mentioned 2 to 3 times, but it does vary between them.
It does. So some of the other ones, like sleep apnea, for example, is much higher, relative risk greater than 5. But the common conditions like coronary heart disease and stroke and some of the cancers, they have relative risks which are more around 2 to 5. Which is fairly common. In relation to the proportion of people who have these, proportion of obese people who have these comorbidities, you can see it on the slide there at the moment that even though there is that very high relative risk for diabetes, for example, its occurrence in obesity is around 15 to 20%. But when you add up all those other risk factors for heart disease, hypertension, hyperlipidemia and so on, you start to get a large number of comorbidities likely to occur in people with obesity.
And Lillian, what do we know the number of years life lost to this?
You can take an example of a 20-year-old who's morbidly obese, that is, he has a BMI of 40 and above. He would have a relative risk of developing these comorbidities of about 300 times, which equates to about 15 to 20 years of his natural life.
So this graph here shows the impact. So it's and Melanie, are you convinced that reversing it reverses the risk?
Yeah, absolutely. There's a lot of evidence to show that by helping people to lose weight, that's going to reduce their risk of both morbidity and mortality.
And the reasons, Boyd, for all this?
Well, some of these things you can actually reverse the condition. I mean, sleep apnea is a classic. If they lose sufficient weight, then they can lose the whole condition. Even early diabetes, when people first present, if they lose significant weight, they can lose their diabetes, and we see that with gastric surgery. But these other conditions, it's more like a risk factor. So, for example, with coronary heart disease, if you reduce weight, then you reduce blood pressure and hypercholesterolemia.
It's a more indirect route.
Yeah, it's a more indirect route, exactly.
John, what's the issue with general practitioners here? Because you almost get a sense of nihilism about it. They give up before they start.
Well, before I answer that, let me just put in a plea that says, this is such an important topic. Why is it that there is so little money in it? I cannot believe that something that is so important, obesity itself is not recognised as a disease, and if I'm seeing someone who is just obese, I can't charge them an item number for managing their obesity. Is there a nihilism? I think one of the problems is that I don't think we have convinced my colleagues that this is actually really important. And I know that because when I ask around as to how many of my colleagues actually do what they ask their patients to do, the answer is invariably that they don't. And yeah, we see it every time we go to a conference. If you measure the waist circumference of the doctors that go there, you'd be just horrified compared with your patients. So
unlike smoking, which doctors have changed their behaviour and therefore can set an example to patients, they're not doing it with obesity.
They're not walking the walk. Well,
literally. They're not pedometering the pedometer.
Well, can I reach in and show you that I'm one of the converted?
Yeah. How many have you done today, John?
15,127, which is a good start.
Very good start.
I spent a day travelling on an aeroplane so that it's interfered with my normal day, but yeah.
And you think this is a disorder of motivation?
If we don't understand that it's important, we don't do it. If we think it really is important, we do it.
But we'll come back to some of this in a moment.
It's motivation, but boy, the environment out there is tough for
So
people.
let's talk about the environmental factors that determine obesity, and therefore that would go to what you might be thinking of, particularly as a doctor advocating in a local community for change. So what are the issues?
Well, I think the first issues that the people see, of course, are the behaviours that lead to this. So the kind of the overeating and large portion size and not exercising enough, and we do need to deal with that. But we do have to understand that there is a whole change to the environment that's making this tougher for people. And for people who are trying to lose weight, the environment out there is actually not helping them very much at all. In fact, it's pushing them towards more obesity. And this is why we've had this change across all these countries all about the same time. And we've done some work on that, trying to analyse what has been the driver of the epidemic. So I'm talking about at a population level now. And almost all of it in most of the wealthy countries is related to increase in energy intake. Now that's not to say that we haven't got a sedentary lifestyle and that's not adding to the problems, because it is. But a lot of the changes over time have because of the change in the food supply. It's cheap, it's tasty, it's there, it's promoted, and it's easy to get a hold of. And so when foods are like that, we eat more of it and get fat.
And I mean, it seems that that's, how do you counteract it? What is the importance of advertising? People talk about, the National Preventative Health Task Force talked about getting rid of junk food advertising for children early at night. How important is advertising in that?
Well, I think it's critically important. That changes our whole perception of what is normal and what's not normal. If we had bans on junk food marketing to kids, that would raise the awareness and take it out of this sense that this is just normal and this is just everyday wallpaper, that this is actually not the right thing to do. It's not ethical to be promoting the types of food that promote obesity in our kids. So just like with tobacco, when we start getting into this at a policy level, then you start seeing some cultural change and you start seeing people pick up on it and respond to it. So school tuck shops is a good example. You know, if we can get the junk food out of school tuck shops, that sends a strong signal to the kids, to the parents, to the community. This is just not good enough.
So it's both an intervention at a local level and has symbolism attached to it.
Absolutely. I call those lighthouse effects. So the fact that kids may not get a large proportion of their energy from school tuck shops, maybe 2% out of the whole year's energy intake. But if the school says we're going to have a healthy tuck shop, that is a lighthouse. It sends lights out to the parents, to the kids, to the community. This is what healthy food should look like. And
that's an important role for general practitioners to advocate for that in the local communities.
Not only that, but the whole concept of a healthy lifestyle. I think the GPs can become advocates, go and speak to your local members of parliament, local council, about constructing and planning laws, about...
Yeah, well, I mean, talk to me about urban design in country towns, because some successful country towns are trying to emulate the worst practices of the cities.
Yes, we were discussing this earlier, that if you have an environment that doesn't encourage you to exercise, then you won't. If you've got to take your car with you because nothing is accessible, then that's what you'll do. We've got to somehow work around that.
So the sort of sense in a country town is that you're there for the great wide open spaces, but in fact, if you're going to live in town, we should be consolidating, live closer together so that you're walking more.
Indeed.
And this goes along, isn't it? I mean, arguing for environmental conservation, in a sense, also goes with weight loss.
Oh, absolutely. And I think that particularly on the physical activity side, anything that promotes active transport, walking, cycling, public transport, is good for the environment, for reducing carbon as well as for health. And even on the food side, you know, reducing processed food, processing and packaging and things costs carbon. So in some cases, health may not be the main driver. It may be congestion, it may be reducing greenhouse gases, but they're good for health in the long run.
Yeah, Manhattan is the world's most, one of the world's most energy efficient cities, and you don't see many fat people in Manhattan, but that might be the body beautiful and down Park Avenue. Do you still get people coming in to see you, Melanie, who think it's my genes or my glands?
Yes, on a regular basis. And I think for
Mind you, some glands do get very fat.
True. But then it's about taking them down to basics. A lot of people are still really unaware of how many kilojoules are in different foods and how much energy it takes to walk that food off. And so often it's just about explaining things to people and actually showing them how much they're actually eating in a day.
So could it be that general practitioners and indeed others in the health field are overestimating what people know? They assume that everybody knows this, therefore I'm not going to bother explaining it.
Definitely, and I think that's something that I even struggle with myself, is having to explain some of the really things that seem really basic to me to other people, like what is a portion size of meat? You know, you see people out there who have 400, 500 gram slabs of meat for dinner, and unless they're going out, playing football for 5 hours, they're just not going to work that off.
Mind you, they think that they spend the day on the tractor, they're working.
Exactly.
That's right. But the other problem is that what we're talking about here is actually too hard to do in a general practitioner's surgery. The moment you embark on that sort of detail in a consultation, you're committing yourself to at least a half an hour or more of consultation time, which is just not going to get done. So I think that...
So what's the model in your practice?
Well, again,
Actually, before I ask you that, just to finish off that comment with Melanie, what proportion, just as a guess, what proportion of people that you see
Yes.
respond, all they need is that information, my God, that's the number of calories, or goodness me, I had no idea that that plate of rice is actually 6 portions of carbohydrates,
Yeah.
and that changes the behaviour, just the knowledge.
I wouldn't say that is the only step, because for a lot of people it's knowledge plus the assistance to make changes to behaviour. And making changes to behaviour is quite difficult. And so that's where people need regular follow-up, they need motivation, they need encouragement, and they need to be able to achieve in small steps so that they have the confidence to then keep on taking more and more steps.
I was going to ask you about the model in your practice.
Sure. Ours came out of a recognition that it was just too hard to tackle on our own, and it coincided with the government's release of the life scripts material. We've got a little pad of life scripts, quite useful, but doesn't go far enough. One of my practice nurses had an interest in this area, and so we've actually set her aside from practice nursing and getting her to just see patients. We are using opportunistic intervention just to broach the topic with our patients, and if they're interested in carrying on with something, we then say on the way out, make an appointment with our nurse. As I said earlier, there is no funding.
So she can't claim an NBS item?
She cannot claim anything, and we would lose money on it hand over fist, except that the way that we've done it is that she spends half an hour with the patient. At the end of that time, she'll give me a ring. I'll pop in and say, okay, what have you got out of this consultation?
So you'll have a short consultation?
Yes, a short consultation with them. We can charge for that. The only expense that we insist on is that each patient buys a pedometer, otherwise it's all bug pulled.
Do they use the pedometer?
Well, it's part of the program, and they get asked every time they come in, and we have a little record chart of just to fill in to say, record your steps on the pedometer chart and bring it with you each time you come. And that's just a really useful thing. The pedometer, the model that we use is one that will collect steps that are done at more than 10 minutes at a time, so that they call them aerobic steps, and that gives us an idea of what dedicated activity they're doing. That's a great motivator, especially men love it, and they love doing tallies and averages and adding them all up. And just increases the accountability level.
I think what John's describing is a kind of a system that he's developed within his practice around monitoring and support, which is really what's lacking. That's the piece that's really lacking, unless it's established within a primary care, or in New Zealand when they had the equivalent of life scripts, which is green prescriptions, they also funded some support in the community for the checkup. So that's the real piece that's missing, I think, in primary care, is the systems for monitoring, checkup and referral.
We think that general practice has a secret weapon, and that's an ongoing relationship with patients. Now, my practice started in 1892, and so we've got a long history.
1892?
1892. We think we're the second oldest in
You're
Australia. You'll get a phone call about this later. But because patients are going to keep coming back, they know that if I log them in as attending our lifestyle sister, that I'll be asking them, how's it going? And just to know that they're going to get that question.
And have you monitored what sort of results you get?
We think, yes, we have. I don't have the figures with me, but we're at least as good, if not better, than anything else around as far as lifestyle modification goes.
And they get dietary, eating advice, plus exercise?
And accountability, yeah.
Monitoring. And that's quite important, Melanie, isn't it? That you are, that's one of the key features, is constantly measuring.
Absolutely, and it doesn't matter whether it's somebody who's had weight loss surgery, or whether it's meal replacements, or whether it's just diet alone, or all of the programs. One of the key features that keeps on reoccurring is accountability.
Talk to me about expectations and the evidence there, because what do people expect when they come to see the doctor or dietitian, and what's the reality?
Well, people have much greater expectations of what they're going to be able to lose, and John and Melanie be able to talk to that more. But the reality is, from the trials, is that the expectation of weight loss is of the order of 5 to 10% of weight is about average for trials, which is good for health, and that will improve health.
It might not give you
indicators.
the Brad Pitt abdomen, but it gets rid of your diabetes and your hypertension.
Absolutely. So that's the amount, but there's also an expectation of how quickly they think they can lose it. And I think that probably a big part of the initial sorting things out with people is working out the expectations and bringing them into line with reality, because once you make a change, then for weight loss, then that will continue on for a period of time. You'll strike a new plateau. The half time for that change, by the time you lose half the weight, that's about a year. It's a long time. It's a long half-life, and people have to realise that, and they're in for it for the long haul.
And you've got some interesting data on when you sort of lose the motivation and start going up. There's a paradox.
There is a paradox that people that go on very hypocaloric diets, really go on crash diets, and they have a very low calorie diet and they're losing weight. And then they can't stick with that, and the diet keeps creeping up, and the intake keeps creeping up, but they're still hypocaloric, so the weight is going down
so they
at
think
the
they're
same time as the energy intake is going up, and that's what causes that eventual turnaround in weight and the return back to the original weight.
So they're lulled into a false sense of security.
Yeah, they are, absolutely. So this kind of crash diet approach, I think, is one of the pitfalls of it.
What do you say to people about their expectations for weight loss? Should be. Well, how do you set expectations?
Yeah, look, I think that's one of the first things that has to be done in the initial consultation, is that you need to sit down with your client and come to some mutually agreeable goals. And it is really going to depend on why they're losing weight. So, for example, if you've got somebody who needs to lose weight quickly for surgery, then you may need to use a tool to help them lose weight a bit faster, like a very low energy diet. Whereas if somebody is trying to make much longer term changes, then maybe some smaller steps are going to be a better choice. There's some interesting data released recently that showed that people who lost weight more quickly actually had more motivation and lost more weight in the long term. So I think that's
so getting an early win on the
exactly.
On the
so sometimes you do need that extra motivation.
John, do you agree with that?
I think one of the issues that GPs have is how to sell the issue. My dad was in management. He used to say that the art of being a good manager is making people want to do what you want them to do. And so it's up to us to become really good at motivation and at challenging our patients. And so first of all, obviously, we have to believe it in ourselves. And then we need to put in some work at learning how to involve people. For example, if I say you're overweight, you should do something about it, I'm going to turn the patient off. But if I challenge them with a question of how do you feel about your weight, I'm actually making them engage in the consultation. It's just a little technique. You can't resist a question. Your brain always will answer it. Just learning little skills like that is well worth it.
We've got some questions.
Motivational. That's classic motivational interviewing.
Yeah. So work at learning it.
Question for you, John, from a general practitioner. A patient presents who's male, 68 years old, morbidly obese. He's obviously an overeater. His swimming is his only exercise. Walking is too painful. He's gout. And if walking is too painful, what are your suggestions for looking after this man? Send him to Lillian?
If he's morbidly obese, then that may be the best option if he's had a multitude of things to trial, because I think that bariatric surgery is a wonderful opportunity to turn it round for patients, but it's not the ultimate endpoint answer. It's the beginning of the new lifestyle that they have to... on the same basis, I don't encourage my patients to buy exercise bikes. I'll say to them, if you are exercising and you want to do it more easily, by all means buy the bike, but if you're not exercising now, don't buy the bike to start with. There needs to be some change in the heart before you can actually have a win.
So Lillian, we'll come to the surgical options later, but can you, when you're morbidly obese, can you turn it around without surgery, is it in reality?
For the very motivated person, yes, you can, but it's a very difficult journey. For many patients, they've had eating habits and old habits that they just cannot get out of. Sometimes surgery is the tool that's required to turn them around.
Because just exercise is hard to do. You know, just everything's harder when you're that heavy. Another question from a general practice nurse in North Queensland: how do we overcome the problem of lack of physical activity in remote rural properties where climate and distance means they ride more than they walk? John?
I think, again, it's up to us to explain, when you listen to the figures that Boyd's given us about how potentially disastrous overweight is, that if we can sell that to the patient to say, this is important, your life depends on this.
But what tricks do you give people when they're out on a property and it's so vast that, you know, they've just got to get around it in a motorised way? In the same way I could say that my occupation is sedentary, that I have to sit down and talk to my patients. I can't walk around the room while I'm consulting. But if I recognise that because of the way that I practice, I now have to not rely on incidental activity but dedicated activity to take the place of it, then I start to say, okay, well, I now have to look for opportunities to do it. Talk to me about incidental exercise. I mean, to what extent? I mean, the trendy thing at the moment is standing.
Right.
Everybody's researching standing,
yes, I know,
rather than sitting. I mean, does it really cut it?
Well, it's pretty new, this science, and I can't see it cutting it. The issue around incidental activity is very important, and particularly I think this is where urban environments where things are closer together, where you can walk between them, it adds up to steps. John was just saying when he was working in a hospital and walking the corridors and things, that all that stuff adds up and adds to steps, whereas if you're sitting down it doesn't. So this kind of activity that's built into the day, to your transport or to your...
But I understand what has been done at the Sydney University and the Baker Institute in Melbourne suggests that you can add quite a number of calories to your day's burn by just standing instead of sitting at work.
That's true, but then again you've got to put people through a motivational program to stand at their desk and to stand rather than sit, and we haven't seen the evidence that people can do that for long periods of time.
Question from an Aboriginal health worker in the south coast of New South Wales who's watching: is there any genetic factor for Indigenous people related to obesity? Boyd? Well,
a lot of populations have been studied for potential genetic factors leading to obesity. The groups that I work with, particularly the Pacific Island population, which has the highest rate of obesity in the world, with like 90% of the adult population overweight or obese. And their genes have been studied. I used to work with the Pima Indians in the US, another group with 2/3 of the population with diabetes. This has been studied with millions and millions and millions of dollars, and nobody's come up with any genetic pattern. My personal view is that a lot of these differences, large differences we see in obesity between populations, have much more of a socio-cultural basis around perceptions around body size, around food, how food is used for hospitality, around perceptions around value of physical activity, those sorts of things. That's hardly been explored, but I think that probably does explain quite a lot of differences.
But if you take, for example, Indians, not American Indians, but Indians in the South, South Asians, or Chinese Australians, I mean, they hit a higher risk at a lower BMI, don't they?
They had a higher risk of diabetes and heart disease,
yes.
At a lower BMI, that's true. And so some of those countries are using lower thresholds for intervention, for clinical interventions, that sort of thing. So yes, that's true.
And as a GP, presumably, you've got to be more alert to that, and presumably everybody who's not Anglo-Saxon or Mediterranean.
Yeah, that's right. A lot of the studies, of course, have been done by white researchers, and then they say, oh goodness, the Indians have a high rate of diabetes, goodness, the Pacific population has a high rate of diabetes. Everybody has a high rate of diabetes, actually, than white people. So, but general practitioners, I'm sure, are alert to that.
At Longreach, they know what to do. For a country town, they actually have local resources there. They're willing to bring them together, but it's not necessarily all working out. What are the suggestions here? Well, you work in a multidisciplinary setting. You have to for surgery. What tips can you give people at Longreach for actually getting effective multidisciplinary team-based care for people who are wanting to lose weight, or may not even be wanting to lose weight but need to lose weight?
I think the essential part of a multidisciplinary team is working together, giving the same message to the patient in a different way. So for example, when I see the patient, I tell them what they must do to get successful surgery. But the dietitian, when they see the patients, will tell them what they should or shouldn't eat to help to decrease their calorie intake. I have a lifestyle coach to help them deal with their emotional eating. I also have a physical physiotherapist who help them do the exercises. Admittedly, my patients can't exercise very well, so we tailor our exercise program for toning rather than aerobic exercise.
So it's actually meeting together, talking and singing from the same hymn sheet.
We meet very regularly and we change our program all the time to suit our patients.
Melanie, you don't work in a multidisciplinary team.
Oh no, I do.
You do? You do?
Yes and no. I do both.
So what tips, I mean, and you're in Melbourne, so you're lucky, you're in a resource-rich environment, but trying to transplant this to Longreach, what's your advice?
Two things. First of all, I think that there are a lot of programs out there to upskill practitioners on behavioural modification and motivational interviewing and just ways that we can actually engage with our clients more. So that would be the first thing. The second thing is that there are some great evidence-based tools to help people to get faster results from their diets and from their weight loss, such as meal replacements and surgery and pharmacotherapy. So maybe instead of maybe they need to actually upskill in some of these areas and use some of these tools that are available. But
you don't believe in pharmacotherapy?
I don't. I don't think, well, I'd like to say that I finished my career never having prescribed it. I regard that as a bit of a failure. I think from Longreach point of view, that the GP has to be the team leader, that our role is to identify the problem and to motivate the patient. I think that the success rate is low. In my career, I've never walked away from a cardiac arrest, but I've never really gone into it thinking this patient is going to live. And they mostly don't, but they sometimes do. So we're dealing with another area that has a very low success rate, but that doesn't mean that we shouldn't try. I think it just means that we haven't really gotten on to how to do it best. I think Melanie's right that if you involve your local division and say, we want some training in motivational interviewing techniques, in obesity management, and try and upskill yourself so that you understand that it's important. I think that you have to mirror the importance of that lifestyle by doing it yourself.
And just with meal replacements, I mean, you're talking, one of the themes here is that it's a good thing sometimes just to get people over the hump and just get them losing weight, and then you can transfer onto other things. But in a country town, people often just don't have the money, or it's not available.
Normally, meal replacements are cheaper than eating.
Exactly.
Really?
Absolutely.
Yes.
Yeah.
You can't make a meal for $2. You can buy a sachet of meal replacement for $2.
Really? I didn't know that. Lillian, what's the relative benefits from, according to the evidence, of surgery, when you go down the list, pharmacotherapy, lifestyle, and so on, in terms of percentage weight loss?
If you look at all the options available, surgery many studies have shown to be the most effective in amount of weight they lose as well as sustainability of weight loss.
Boyd, the 5 to 10% is really pretty good if what you're wanting is health.
5 to 10% will get you improvements in blood pressure and lipids and glucose, that sort of thing. But for people with a BMI over 40, they obviously need much more than that. And I think for people at that level, I think they're trapped in a whole lot of vicious cycles. They've got the back problems, they've got the knee problems, they've been on crash diets, they've got psychological cycles that they're trapped in. They might even be trapped in socio-economic cycles of where disadvantage begets obesity, which begets disadvantage. So, I think we have to recognise that a lot of these people are relatively trapped, and surgery is a circuit breaker, there's no question about that.
How much exercise is in the prescription here for weight loss and weight loss maintenance?
Well, there's studies that have been done on people that have been obese, that have lost a lot of weight and kept it off for a long time. And the things that they do are they do a lot of exercise. They do an hour and a half of exercise every day religiously.
And this is moderate exercise where you're getting puffed?
Yeah. And they watch their diet. They do what the dietitian says. They follow. This is not rocket science. You do what the dietitian says.
Small portions, calorie controlled, eat slowly.
Low fat.
Low fat.
Low fat. And the third thing they do is they monitor.
So they weigh themselves daily.
They weigh themselves, or they keep a check on the waist circumference, or even diet diaries, that sort of thing, pedometers. They have systems which give them feedback for it. So that's what successful people do. But that's tough to do, to go down from very obese down, lose a lot of weight and keep it off. People have to work at it every day.
And that's where I see the role of general practice, Norman, because I think that because our patients are going to be seeing us several times a year, we have the ability to provide that feedback that says you're accountable to me and I'm actually interested in what's happening.
What about diet cycling?
Yeah, it's a huge problem because there are so many dangerous bad diets out there where what happens, people lose a lot of weight quickly on something that's very unnutritious. It's low in protein, they lose muscle mass, they become disheartened, and because they're losing this muscle mass, it'll slow down their metabolic rate and put on more weight again. So that's why I think it's really key that when people are going to lose weight, particularly if they want to lose weight quickly, which a lot of clients do want to do because of our culture, they need to be doing it in a healthy way, something that's evidence-based.
And sustainable.
Yeah.
But that's a challenge, because when they come in, they're motivated, right? And you don't want to sort of squash their motivation. They want to get rid of weight and they want to do it quickly.
And again, that's where you use some of those evidence-based tools like meal replacements or surgery or what have you to get some weight off quickly. But then from there, the key thing is the lifelong changes. So it's not just go on meal replacements and then come straight off again. It's go on meal replacements, so you've got a blank slate, and then work with your dietitian or practice nurse or whoever to slowly re-bring in one meal at a time and show them what does that meal look like, how big should it be, what type of food should they be
Do you ever
eating.
recommend that they should continue with a meal replacement forever?
I don't, but I do have some clients who struggle to get off them because they just love the convenience of them. And I say that's fine to keep them at home if you're travelling or if everybody else is getting takeaway food or you want to have one for brekkie, fine, no problems. As long as they're doing it in a way that they are nutritionally complete. Often, particularly for some of your larger clients, 3 a day is not going to be enough. So it needs to be calculated so that people are actually meeting their nutrition requirements.
And what about things like B vitamin supplements? If you're on if they decide that they're going to go on a really extremely low calorie diet, do you have to watch if they're going down from a high BMI and they're really crashing down?
There are lots of things that you need to be monitoring. And so if somebody is wanting to lose weight quickly, then I think that they should definitely be doing it under the guidance of a GP and dietitian working together.
So let's say they're really they're focusing on a crash diet and they want to lose weight a lot. My understanding is that nutritional deficiencies are a serious issue if they're going down from, say, 7,000 calories a day to 2.5.
Yeah, absolutely. And in those circumstances, that's where I think it's dangerous for people to be doing this out in the community without any assistance. And I actually have an issue with the marketing and things around some of the fad diets that are out there. I had a client come in who went on a juice-only diet. She paid something like, it was astronomical, it was $400 a day or something like this. All she drank was these different concoctions of fruit juices. I just thought, how is that legal in Australia?
Indeed. Give us some behavioural tips that you give people to actually help change their behaviour in a sustainable way.
Okay, so I guess mindful eating would be one of the first things that I'd be looking at, because I find a lot of my clients eat for stress or social, or just because they're used to serving up those volumes of food. So actually getting people to keep food diaries so that they're aware of what they're eating. So it's teaching people to be conscious of what they're actually putting into their mouth. A lot of people
Does that mean no television while you eat?
Absolutely, so that would be one thing. So they actually need to concentrate on what they're eating.
So you eat as a family, the television is off.
Television is off. You need to be eating regular meals throughout the day, so we don't want people having brekkie at 6 o'clock in the morning and then not eating again till 3 and then grazing from 3 till midnight.
Because most fat people eat most of their calories after dark.
Absolutely, yeah. So that's a very common thing that I see. So looking at portion size.
So we just go back to the mindful eating. So it's slowing down, savouring it, eating slowly, and small portions.
That's right.
And I think there is some evidence that eating slowly, small portions do actually reduce the calories you eat, just in its own right.
Absolutely. And so Yeah, again, we want people to be really aware and conscious of what they're eating, because a lot of people just don't understand how many kilojoules they're taking in a day and what it takes to work that off.
Now, somebody once told me that, pretty non-evidence-based, but anecdotally, that highly spiced foods are a problem because they are so attractive and you tend to eat more of them. So you want to actually slowly move down to lower salt and slightly blander foods because you will actually eat less of them.
I'd actually disagree with that.
Sounds like a terrible recipe. I'm sure the French and the Indians wouldn't have.
Well, French do eat highly spiced foods, but
no, but I mean, taking away the enjoyment
of food. Yes.
I mean, let's not turn this into a medicine. You know, food's there to be enjoyed.
Exactly, and that's one of my mottos, is that it should be about quality, not quantity. And I think another problem that I see a lot is women in particular having diet foods, and they have just loads and loads of these empty kilojoule diet foods, and they're not actually getting any nutrition or any enjoyment from them.
And it's got to be a sustainable change to your lifestyle.
If you're going to have chocolate cake, have a decent piece of chocolate cake, but have a little bit of it rather than having a huge slab of diet chocolate cake. Yep.
How long should follow-up go on for? Because there is evidence that follow-up and regular contact with somebody who's monitoring you makes a difference. How long do you follow people up for?
We like to think that it takes about between 1 and 1.5 years to change a habit. And so it's been our experience. Our little program has been running for about 3 years, and we find that people like to keep coming back anyhow once they get into it. But after about 12 to 18 months, they're pretty well self-motivated, provided they don't drop out in the meantime.
But you still run the risk of relapse, don't you?
Well, if you've changed their lifestyle, and as Boyd was saying, that people who are overweight, once they've been overweight, need to exercise for at least an hour a day. Once they've got that and they see the success that it gives, it's such a powerful, positive feedback, they'll do it.
But they keep coming back to you. I mean, an average person sees a GP every year, so they keep coming back.
Monitoring anyway.
They keep
doing the monitoring anyway.
Let's go to our first case study. Okay. Diana is 36 years old. She's a married mum, 2 kids, lives in the country town. She weighs 78 kilos, is 165 centimetres high. Her waist circumference is 93 centimetres. Her blood pressure is 135 on 85. Fasting blood sugar is a little bit up, 5.7, more than a little bit up. And her father's got a family history of type 2 diabetes, and she's come to you for a pap smear. You're a patient, Dr. Pearson.
Oh, right. Well, this is a great opportunity.
Given the time for a GP consultation, you've just wasted about 40% of it.
I think that what we're dealing with here is an unmotivated, opportunistic intervention. This patient has come to you for a pap smear. That says she's interested in her health, but she's not come to talk to you about her weight. And I think it's a great opportunity to say, well, while you're here, can we talk about to ask permission, can we talk about your weight?
So Lillian, what would be her BMI? What about?
I think we're probably about 29.
So she's under
overweight.
Overweight. And she's got a waist circumference that's, what, 5 centimetres over the odds?
Yep. She's redeemable. We can fix this lady.
Mm-hmm. So how do you get her motivated?
Well, first of all, having gained her permission to talk about it, to talk to her about some of the statistics that we've already heard from Boyd about how important it is for her to change, because without change she'll continue up
She's going to track upwards.
Yeah. And so in a few years' time she's at major risk of major medical morbidities.
And in fact, you don't have to eat that much more to track upwards.
No, she's on track. She's on track for a disaster.
So what would you do for her, Melanie?
Well, I mean, it's a bit hard to say. The first thing I'd be doing is a detailed assessment. So I need to see how much exercise she's doing, what she's eating, what is it that's causing.
So she's got 2 kids, she's full on, she's got a job, and in fact she was here the week before, and her 10-year-old's pretty fat too.
Yeah. Yep. But it still could be quite a few different things in her diet that's causing the problems. She might have it.
The GP would say, do you have a dog and is it fat too?
Because it ain't getting walked.
Whether it goes
right. She may have a great diet but then go home and drink a bottle of wine each night. Or she may have a great diet but just have 2 large portion sizes. She may have a terrible diet but do lots of exercise. There's unlimited combinations.
So you've got to spend time getting to the bottom of it.
You have to do a decent assessment first, and I really think that that's the problem with a lot of these one-size-fits-all programs, is that everybody is different, and you need to do a good assessment and find out what the real issue is for her.
So just an anecdote. I mean, I used to be much fatter than I am, and I went to see a dietitian. So our first dietitian was nice and friendly, and sounded like you, and I didn't lose weight. Or I lost weight and then I put it back on again. The second dietitian was a fascist, was a Nazi, and she took the dietary history, and I thought I was going to get this complicated analysis, and she told me that I ate too much,
Right.
and that I was going to be very, very hungry. Now, just in a bit of a reality check here.
Yes.
In terms of expectation.
Yeah.
So you commonly hear you must never be hungry on a diet. Do you lose weight if you're never hungry?
I think that, yes, as long as you're filling up on low kilojoule food, so low starch vegetables, etc. And if you look at the statistics, less than 10% of Australians are meeting their requirements for vegetables. So I think that one change in itself is going to have a huge impact. But at the same
Can I
time...
support you on that one? Because we've just embarked on getting everyone in our practice over the age of 40 that comes in to do the Oz de-risk tool. And one of the little questions is, do you eat fruit and vegetables? And I am horrified at the number of people that tick they don't eat any fruit and vegetables.
Yes, well, exactly. I've met people, like kids who have never eaten a tomato in their life.
Okay, so education, knowledge...
But the other thing I was saying about feeling hungry is that there's also that other end of the spectrum where some people are very scared to feel hungry at all, and they just want to feel overfull, and if they're not overfull by the end of the meal, they're scared. And so that becomes a little bit of education. I tell my clients that you should actually be feeling hungry before the next meal, and if you're not feeling hungry before the next meal, you probably ate too much at the last meal.
What about the kids in this scenario? I mean, if she's got overweight kids, one in 4 kids that are walking through GP offices are overweight as well. And I think getting the whole family engaged in the health of the kid can often be an important motivator. And we know from studies that dealing with overweight kids, the family absolutely has to be involved. They have to take it on as their problem, as their issue.
Let's go to our next case. Well, just before we go on, and how would you monitor, Diana? Just weight? Just the scales?
Well, personally, we assess everybody's body composition, so we look at their percentage of body fat. So we want to make sure that she's maintaining all of her muscle mass and just losing fat. So that's something that we do in our practice.
Can I put that into general practice terms and say that in our practice, when we're monitoring people in this program, we do 2 measures. One is waist circumference, and the other one is that we've invested in a couple of sets of bioimpedance scales. They're actually quite cheap. A couple $100 will buy you a good set of scales, and pop them on there. That measures your body fat percentage, and we think that those 2 measures are actually much more useful than weight. And we always warn our patients that as they start to become more active, they can actually weigh more as their muscle mass increases, because muscle weighs more than fat, so that weight is not a particularly good measure. What they want to, when they come in, what they want to lose is not weight but size, and what we're offering them is to lose size by measuring their waist circumference and their fat percentage.
How do you monitor them after surgery?
We measure them, we weigh them, and we measure their waist circumference as well.
And what do you think about this issue of body composition and lean muscle mass and things like that?
I think it helps the patient. They like to know their progress. If you actually have a measurement that you can give it to them, they actually chart it and actually chart their progress, which is really great for the patients.
If you're dealing with an opportunistic intervention, to actually be able to say to the patient, you are carrying 40 kilos of fat, that's a tool that you have to say, okay, I better do something about it. I didn't realise that my body was that much fat. Confronting them with some home truths is a really good way to tip the balance into saying, I'll do something.
And then you give them those little fat globs.
But one of the things about body composition, when you gain weight, you gain, for every 3 kilograms of fat you actually gain about 1 kilogram of lean mass. Your muscle mass gets
you've got to carry it around.
Your liver gets a bit big in your heart. So when you actually lose a lot of weight, particularly Lillian would see this, when you lose a lot of weight, you actually do lose lean mass. There's no way you can avoid it, because that's what the lean mass was there for in the first place, to maintain the body size.
So you shouldn't panic about it.
You shouldn't panic about it.
So you could actually get confused by doing the body mass, the body composition.
You have to realise that with weight loss and with substantial weight loss, losing some muscle or some lean mass is inevitable.
But it also underscores the importance of commitment to an exercise program
to maintain
what
try
you've
and
got.
maintain it.
Which is a multifaceted exercise program, which is not just aerobics, it's strength training as well.
Yes, indeed.
Build up that old skeletal muscle. Let's go to our next case study, who's Susan. She's 31, having trouble getting pregnant. She comes to your clinic, Melanie, wanting to lose weight quickly, and her BMI is 32. She's tried lots of diets in the past and hasn't had much success. She used to smoke, and she blames her weight gain on giving up cigarettes. What are you going to do for her?
This is actually quite a common scenario that we're seeing in our practice now, where we're particularly being referred by obstetricians and infertility specialists, where we get women who have had multiple attempts at pregnancy and multiple attempts at IVF and come to us desperate to lose weight quickly. And this was one of the reasons for this case study, is that yes, there's a time for long-term changes, but sometimes people actually need to lose weight really quickly. And in that scenario, I'd talk to her and see what were the issues in her diet, but maybe we may need to consider some meal replacements for her.
Just tell us about how you do meal replacements.
Well, first of all, I calculate their nutritional requirements, work out how many that they need, and then what I would do is most of the time, we'd start with a blanket approach where we replace all of their meals with the meal replacements, plus low-starch vegetables.
Does it matter which proprietary brand you choose, or are they all about the same?
No. So first of all, I guess there's a big difference between meal replacements and VLED meal replacements. And
What's
there's
VLED?
Very low energy diets, and there's only 3 available on the Australian market that are VLED, and they're the ones that are nutritionally complete. So they'd be the ones that I'd be recommending.
And how does a GP know, if you've never done it before, which are those?
Am I allowed to say brand names?
Sure.
So OptiFast, OptiSlim, VLED and Kickstart are the 3 on the Australian market at the moment that are
and of those,
nutritionally
OptiFast
complete.
would be the most ubiquitous and easily available in most chemists.
That's correct, yes, yep. And so, yeah, we'd start by replacing all of their meals. And so that gives them motivation because they're losing weight quickly. And it also gives them a blank slate because if they're doing it for a month or so, the program usually recommends 12 weeks, but it depends obviously on the individual scenario. That tends to be enough time to start them off with a blank slate. And then what we do is we slowly reintroduce one meal at a time. And with that one meal, we teach them about what's the correct portion size, what should they be eating for that meal, and slowly bring in the meals. And we've had some great results with it.
If we're talking about the practicalities of how to use this in rural Australia, then the tips that I get back from my patients are that OptiFast is the one they go for because they can get it, that it comes in multiple flavours, but there are only 2 that are palatable, and that's chocolate and vanilla.
Is this like space food? I've never actually seen them. Is this
No, they come in either in sachets that you mix with water or in little, like a muesli bar, but each one of them is a full meal.
They actually come in more than that. So
More flavours, or?
So there are soups as well as, and there's
but
desserts.
I can't get anyone to take the soups.
Well, I actually, because we work with a lot of bariatric surgery patients.
They take anything?
All of the bariatric surgery patients go onto meal replacements before surgery, and I would say that it is completely individual. Everybody has a different preference on what they like. Some people love the soups and hate the bars, others love the bars and hate the shakes, and everyone is different. There is absolutely no pattern, and I've tried to create a pattern.
And do they need to be prescribed by a dietitian or a general practitioner?
You can actually just buy them off the shelf, which I don't think is a good idea because a lot of people won't take enough to meet all their nutritional requirements.
So you've got to have a careful prescription there.
Yeah, that's right.
And do they get pregnant?
Yeah, and look, we've had some great results, not just for women wanting to get pregnant, but also men coming off insulin, a whole range of things.
And what about pregnancy weight gain, Boyd? What's the issue here?
Well, there's 2 issues. One is being too obese and having too much weight gain in pregnancy ends up with big babies, and we know that big babies are more at risk of being obese as adults and getting diabetes. But also at the other end of the spectrum, intrauterine undernutrition and stunted kids and undernourished kids when they come out and catch up weight gain in childhood is also another risk for obesity. It's not quite so much of an issue in Australia, but certainly in developing countries where undernutrition, intrauterine undernutrition is a big issue. That's part of the sort of intergenerational drivers, if you like, of ongoing diabetes and obesity.
And we should just say very briefly, I want to get to the last case study quite quickly, but if you do use drugs, weight loss drugs, you've got to be careful. Recent evidence on sibutramine increasing the risk of coronary heart disease in people who are at risk. Orlistat is not straightforward in terms of that. So these are not ideal preparations. There's no easy route here, which is why presumably you go to meal replacements as your first step.
Yeah, I tend to prefer meal replacements over the medications, but that's not to say that I never use them. I think that there is a time and a place for them. But again, only under careful monitoring by their GP and dietitian.
Steve is 35 years old, he's single, he's got a BMI of 42, he's got hypertension, type 2 diabetes, full package. He's tried lots of times before to lose weight. He can't really do exercise very much, he's pretty embarrassed at the gym. And he's got a desk job at a real estate agent and he's feeling pretty low. Is your patient, presumably, Lillian?
This is a very typical patient that comes to see me, a patient who's morbidly obese. He's got a number of comorbidities that's affecting his health. He's tried various types of diets and obviously hasn't worked. He's now looking for a better solution that diets cannot help.
So what is the evidence base for surgery?
The evidence from surgery is that it is most effective in the long term. From a lot of studies comparing surgery with all other conservative measures, it is the most effective and most sustainable.
So what are the evidence-based guidelines for the indications for surgery?
The guidelines have been set by various health bodies, including in America, in the United Kingdom, and here in Australia, which is the NHMRC. For surgery to be considered, patients need to be morbidly obese, that is, have body mass index of greater than 40. If they are just obese, then they need to have some serious medical comorbidities such as diabetes or high blood pressure. They need to be of adult consenting age.
Although more and more children are getting bariatric
More and more children, but under supervision, because sometimes it's not easy to cope with the restrictions of surgery for young people or immature people. They also need to have continued obesity. It's not something that they've just gained weight in the last couple of months, and that they've shown that they've tried various diets, as well as be also available for regular and long-term follow-up, because it is a lifelong problem.
It's not, this is a fix and you can go away.
This is not a quick fix. We need to help them along the way.
And how do you assess their motivation? Because you hear stories of people turning up for their gastric banding or what have you, and they go back and they liquefy their chips.
Yes, that's true. We chat to them about it, and we also have assessments. We do psychological assessments on these patients to check their motivation, and we also go on a history of what they've done. Many patients have tried diets. The problem with diets is that they can go on a diet and they will lose weight, but they feel hungry. They're hungry all the time, and that's why they can't stick to their little meals. Patients know what they need to eat or what the amount they need to eat, but they just can't sustain it because they're just too hungry.
So just give us the broad types of surgery that you do.
The main types of surgery that we do are to either restrict what they're going to eat, which is a restrictive type of surgery, which is like the adjustable gastric banding, or a malabsorptive, so they eat but they don't absorb the nutrients, or a combination of those two.
So show us the gastric band.
The gastric band is a silicone band with a balloon on its inner surface. This balloon is put around the stomach, and the balloon is also connected by tubing to what we call an injection port. The injection port is placed subcutaneously so that the doctor who looks after these patients can adjust the size of this balloon. How this works is when we place the balloon around, or the band around the stomach, we actually create a very small proximal stomach. The size of this proximal stomach is about 10 to 15 mils, which equates to the size of a chicken egg. With such a small stomach, when patients eat a small meal, they feel full very quickly and they're easily satiated. The presence of the band around the stomach creates an outlet from this proximal stomach to the rest of the stomach. And this is the outlet that can be adjusted according to the patient's needs. You can tighten it or loosen it according to the calorie intake.
And what are the complications?
The first complication for this is that they will lose weight. I tell the patients that they cannot sit down to a big meal or a 3-course meal for that measure. So they have to learn to eat slowly. If they eat too quickly, they bring on a vomiting reflex. And that's when patients do not like it, and they can quite often damage the sutures that hold the band in place and give them what's called a slippage, which is a surgical complication.
And what about failure of the device itself? Does that happen very often?
It's very uncommon. Bariatric surgery is done in only in accredited hospitals, and the long-term results with this is actually very good. A gastric band has been in Australia for about 15 years, worldwide 25 years.
And how long is the follow-up?
The follow-up is lifelong. We tell patients that while they're losing weight, they need to see us fairly regularly. Quite often in the first year, they see us about 5 or 6 times in the first year. As they get better, we may see them once or twice a year for their follow-up.
And the role of the GP in this?
We engage GPs. We have a couple of GPs that work in our practice to help us adjust the bands. And we also like to educate patients in the rural setting to go to their GPs so that GPs can also adjust their bands for them.
So I believe that sort of general surgeons are really getting on the bandwagon here with sleeve gastrectomy. They're starting to do this outside the normal surgical weight loss clinic.
Sleeve gastrectomy is like the new kid round the block. It's a new surgery. It was actually designed as part 1 of a 2-part operation, which is a biliopancreatic bypass. Patients who have this sort of surgery are really too super obese to have their safe surgery, and therefore they have a lesser surgery to start them off with. The sleeve gastrectomy,
can you just leave it as a sleeve?
It seems you can, and that's how it started. So patients who've had the sleeve, which is really designed to remove the lateral aspect of the stomach and leave the stomach like a tube, which is about 100 mils. What surgeons have found is that these patients do lose weight, which is comparable to the other types of surgery.
But you get leaks, anastomotic leaks and things like that, don't you?
The early recovery from this operation is that it's associated with higher complication rate because there is a long staple line. However, in the long term, the stomach can also expand, re-expand, and the patients do regain their weight.
So you're not a fan?
I'm waiting for the long-term results. It's not sustainable at this stage.
And what about Roux-en-Y, bypass operations, pancreabilia,
Roux-en-Y gastric bypass has been around for about 30 years.
Americans love it. It's the one size, this is the one where you don't need the follow-up. You can just get on with life.
You do need to follow up. There are complications. It's been around 30 years. Americans love it because in the 1990s, they did not have the band on their market, so they wanted to do something laparoscopically, and they could do so with the Roux-en-Y. They're seeing complications now.
And when do you use that rather than the band?
The Roux-en-Y gastric bypass would be probably for patients who understand that this is an irreversible operation, and that when staple lines fail or when the stomach re-expand, they need major operation again.
But there's no going back. There's
no going back for this particular operation.
And is there ever a case for biliopancreatic diversion?
In Australia, is rarely performed. It's only performed for very obese patients, but these patients will have a quality of life that's not as good as the lesser operations. The problem with the malabsorptive procedures, these patients have very frequent bowel motions to the order of about a dozen a day.
A dozen a day? Gosh.
When you're losing weight, you think that's worth, putting up with it, but once you've lost weight, patients do not like it.
It increases their exercise activity too.
That's right. Yes, just park yourself away from the thing.
I'd like to make sure that anybody who is getting any of these types of surgery is also getting follow-up with a dietitian, because the research shows that their nutritional status is affected by all of these operations.
And GPs need to be referring to multidisciplinary clinics, Lillian, not just a standalone surgeon who just does this as a part-time exercise.
Well, we know that the results are much better if they have a multidisciplinary team looking after these patients.
So there you are, that's the surgery. What are your take-home messages for those watching, Boyd?
Well, my take-home messages around public policy and environments. So that's where I put my effort in.
GPs as advocates.
Trying to make the environments healthy. I mean, so that the healthy choices are easy choices. So it's at the national level, obviously banning junk food advertising, traffic light labelling, but it can be at the local level. Local councils can do a lot with physical activity, recreation spaces, food available in their own settings, in their own recreation centres and so on.
And don't minimise the impact of a symbolic action.
That's right, the lighthouse and intervention to show the way.
John?
First of all, I think if we are going to talk the talk. We need to walk, walk, walk.
So no more fat bastard general practitioners.
That's it. To know that we certainly can do something, but in rural Australia we need to assess our own availability of resources and to work out a system. Now, in my practice we've said we have a resource here and a resource here. We've brought them together and worked out a system so that I can identify the problem and quickly say, and this person will fix it for you. My role is the scout to find them and push them on. You need to work out your own system. You need to be committed to how big the issue is, how important it is, to work at gaining some extra skills, and if that means speaking to your division about running a few extra courses and bringing in some experts so that you gain the skills. But bottom line, this is important. There isn't much else in general practice that makes such a difference to a patient's life.
Melanie?
Well, obviously I'm an advocate for dietitians, so I think that I know that it's difficult for rural practitioners in particular because they may not have so much access to dietitians, but I think where possible we are the people who spend the time and have the skills to be able to do a really great thorough assessment to be able to identify the key issues with the client, and then where possible really help to educate patients to help them change those behavioural issues. So that's our role.
Lillian?
Well, surgery works. Surgery is effective, but I would recommend it for a proportion of patients whose diet don't work. If they come to surgery, they have to look upon surgery as a tool to help them eat less.
It's not an easy solution.
It's not an easy solution, but it will work with a multidisciplinary team.
Thank you all very much. Learned a lot. Meal replacements, I now know what they are. I hope you've enjoyed the programme too. Thanks very much for all your calls. And thanks to the Department of Health and Ageing for making this programme possible, and obviously for you for taking the time to attend and contribute. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Now, don't forget to complete and send in your evaluation form so you can register for CPD points. I'm Norman Swan. I'll see you next time.